Okay, I'm going to try this again. I just recorded about a third of this and my app ate it, so we're going to have take 2 of chapter 21, blood vessels. This diagram you need to be pretty familiar with. You're going to have this on your exam. It's going to be probably in the format of matching, and it's going to be in color so you can be able to tell arteries versus veins, etc. So it should not be that difficult for you. You also need to know the branches as they come off the aorta. If you look into your course documents, you'll find this, but you'll also find a close-up showing things like the celiac branch, etc. So brush up on these. As a quick review, the types of blood vessels, you've seen this before in previous chapters. Arteries carry blood away from the heart. They branch into smaller and smaller vessels referred to as arterioles. Arterioles keep branching out into capillaries, and capillaries are where the actual business of exchange happens. Capillaries will be getting larger and form venules, and then the venules will keep getting larger and larger as they grow into veins, and then the veins are carrying blood to the heart, and for the respective circulation, remember you have the pulmonary circulation going through the lungs, and then you have the systemic circulation going through the rest of the body. There are 3 layers to blood vessels, and the importance of each layer is going to vary whether you're talking about arteries, veins, or capillaries. But initially, let's simply look at the 3 layers. The innermost layer is referred to as a tunica intima. This is an endothelium, which is simply a type of epithelium with a basement membrane. The tunica media referring to the middle, and this is going to be quite often the thickest layer, and make sure you realize that the muscle that's contained in this is always going to be smooth muscle. So you have sheets that run in different directions. You have a longitudinal direction, and then you have a concentric or circular direction. Finally, the outermost layer of the blood vessels we're going to be referred to as the tunica externa, and this is simply a connective tissue with some elastic fibers and some collagen fibers, and quite often this is simply going to blend into the fascia. So we'll be talking about the layers and their importance as we go through the different types of blood vessels. This is an important slide because I want to make sure you know the differences between arteries and veins. Arteries have a much thicker, more muscular wall, more elastic wall, because they have to be able to handle the higher blood pressure. If you were to look at a cut piece of tissue, and I have, as usual, misplaced my stylus, so I'm drawing this with a finger, so you have to bear with the poor artwork here, but arteries and veins and nerves run together, so you might see something that looks like this. I won't bother to draw a cross-section of the nerve, but a lot of people look at this and they see the larger vessel and they say, oh, that's the artery, when in fact it's the opposite. The lumen means the opening, the inside of a vessel, and because arteries have a much more muscular, much more elastic wall than the veins do, they tend to contract. So the thicker walled vessel with a smaller lumen is going to be the artery. So the other is the vein, and it has a large flat lumen. It's flat because it's so thin-walled it tends to be pushed out of shape. It does not have to handle the amount of pressure being ejected from the ventricles like the arteries do. So we'll talk later about veins being referred to as capacitance, stretchy vessels. One thing to note is that the tunica intima of an artery does not contract, and also veins are different than arteries because veins have to have valves. We're going to be talking about arteries being able to handle blood pressure. Think about the pressure produced by the ventricles. That's going to be pushing the blood through the pulmonary side. It's going to be pushing blood through the systemic side. It does so with a great deal of force. That force dissipates as the vessels get smaller and smaller, so it's pretty minimal by the time it reaches a capillary bed. You go to the other side of the capillary bed, and then you have the veins. There's not much blood pressure remaining to make that blood return to the heart. So there are several mechanisms we'll be talking about later, but let's just say right now, and we'll mention these valves again later, they keep the blood from going backwards, for example, to the feet when you're in a standing position. It keeps the blood from falling downward at the very lowest depressions of blood pressure. This slide simply gives you a cross-section of the different vessels here. Obviously here you're looking at an artery, an arteriole, and the difference is going to be the composition of that vessel wall. Over here, you can see you've got a thinner wall, you've got the much wider lumen. This is representing the capillary, and again, remember, a capillary is simply a sheet of cells that are stuck together. You'll see the same sheet of cells in here, inside these blood vessels, is simply then the endothelial lining. Just wanted to mention something called the vasa vasorum. That means the vessels of vessels. Small blood vessels get their nutrition simply from diffusion across the cell walls. In other words, the interstitial fluid and the plasma will have enough oxygen nutrition for the blood vessels to actually get their supplies from. However, the very thick-walled blood vessels, they have cells on the inside that diffusion can't reach. So they actually have their own set of blood vessels called the vasa vasorum. I'm going to mention now that I have a large dog that has just crawled up beside me and is going to be keeping me company while I do this. So if you hear snoring in the background, that is her. I expect you not to join her in that snoring. Okay, let's look at arteries. First off, you need to know that the largest artery in the body is called the aorta. Arteries require enough elasticity to allow it to handle the pressure, sort of give it a bounce when it receives the blood being driven out of the ventricles. And we're going to be talking about vasoconstriction and vasodilation shortly. Please remember that that is going to be controlled by the autonomic nervous system. If you need to review that, please go back to 141 and brush up on the effects of the sympathetic and parasympathetic nervous systems on the vessel diameter. Arteries are further classified into several different categories here. We have conducting and distribution, and then resistance vessels. Please know that the largest arteries are referred to as conducting arteries simply because they're conducting blood into certain areas, and they are also known as elastic arteries due to the higher percentage of elastic fibers in the tunica media. They have to be elastic to allow us think of it as a bounce of the blood off the vessel walls. The ventricles produce a great amount of force. I mean, your blood pressure is highest where the arteries leave the ventricles than any other place in the body, so they have to be able to absorb that shock wave without rupturing. They branch further into the muscular arteries. These are referred to as distribution arteries, and these have a higher proportion of muscle cells. Again, your medium-sized arteries. Those branch further into the arterioles. These have little tunica externa, and the amount of tunica media is going to vary from area to area of the body. You need to know that arterioles are referred to as the resistance vessels, reason being you have these little sphincters that actually can constrict and increase blood pressure and also restrict access to certain capillary beds. To bring in a term that we talked a little about in Chapter 20, afterload, when you have vasoconstriction at the levels of the arterioles and the smaller muscular arteries, you will end up increasing blood pressure, which is going to increase afterload, which is going to require the heart to beat that much harder to produce more force in order to be able to push the blood out of the ventricles. So understand the concept of afterload. I wanted to give you a definition here of the word aneurysm. You may have heard this before. An aneurysm is simply a weakness in an arterial wall. It may or may not ever rupture in your lifetime. Some people are born with them and are totally unaware that they have them until they're found on, for example, a contrast study, some sort of CAT scan, MRI, much later in life. sometimes, unfortunately, you're totally unaware until it ruptures and you simply fall dead. So there's also different times. There is one type that's referred to as a dissecting aneurysm. It starts to tear and it simply proceeds to move all the way down the level of the aorta, and basically that's typically not a survivable thing. So understand the definition of the word aneurysm. I saw an article, I guess winter of 2013, some babies are born with aneurysms, and some of these cause leakages in the brain, and they just approved the use of surgical superglue to repair those breaks and bleeds. Okay, leaving the artery discussion, let's talk a little bit about capillaries. This is very important that you understand this. Capillaries are the only vessel type that's going to allow significant transfer of substances across the walls of the vessel. So these are known as the exchange vessels. There's no tunica externa, there's no tunica media, there's simply the tunica intima and a basement membrane. So you have a tube made of endothelium, and nutrients and oxygen will pass from the bloodstream into the surrounding tissues, into the interstitium, and the nutrients are then picked up by the cells. On the flip side of that, then, the cells that are producing the waste and the carbon dioxide, that will diffuse from the cells into the interstitial fluid. It'll diffuse back into the capillary walls, be put back into the bloodstream to be carried away and filtered out of the body. There are three types of capillaries you need to know about. The first is going to be the continuous type, and these are by far the most common types of capillaries that you have in your body. These are, again, a simple tube of endothelium, and you have free passage of very small things such as glucose, very lipid-soluble substances such as carbon dioxide and oxygen. But things are too large, such as plasma proteins and cells, are trapped in the bloodstream. They can't diffuse across. There are a few places in the body that you have some specialization, and the main example you need to know about would be the blood-brain barrier. Astrocytes are the type of glial cell that produce a special barrier that protects your central nervous system from things that would cause devastating effects where they'd be able to penetrate into the CNS. So, in other words, there have probably been many times in your life that you have accidentally inoculated yourself either through the GI tract or through a cut injury with bacteria. They go through your bloodstream. They're at some point yanked out by phagocytes, and they cause no harm. However, if those same bacteria were to be able to penetrate into your meninges and infiltrate into the brain or spinal cord, you could die within a very short period of time from a really nasty meningitis encephalitis. So that blood-brain barrier gives you that extra layer of protection. Flip side of that would be that when you're trying to treat an infection of the central nervous system, you're going to have to use an antibiotic that is going to be soluble to that blood-brain barrier. Same thing with general anesthesia. You have to make sure that your anesthetic is going to be something that can actually pass through that barrier in case you're trying to create a general anesthetic. Second type of capillary is going to be a fenestrated capillary. If you know what a fenestrated drape is, then you'll know what the word fenestration means. Picture a fenestrated drape as being the type of protective barrier they use in a surgery, but it's got a hole under which the incision is going to be located. So a fenestration simply means a hole. So fenestrated capillaries are made up of endothelial cells that have little pores in the cell that allow things to pass through. You'll find these capillaries in the choroid plexus, which is where the central nervous system creates the cerebrospinal fluid that's filtered out of the bloodstream. You'll find it in endocrine organs to allow passage of molecules of hormones because they tend to be larger in structure. You'll also find them in the kidneys and in the GI tract. The last type are referred to as sinusoidal capillaries. instead of having pores in the individual cells, like the fenestrated capillaries, now you have gaps between the cells. So the cells don't have holes in them, you simply have cells between the gaps. And these capillaries don't even have the basement membrane. You'll find these in areas where you need really large particles to be able to go through. Liver, spleen, endocrine organs, and the bone marrow. So some of the structures that, or some of the things that can move through these capillary gaps are going to be the large plasma proteins. There is so much free movement across the wall of these capillaries that the body has set up a special sentinel or guard at these openings, and these are the phagocytes. I'll give you an example. When we start talking about the GI tract, we'll be discussing the liver and the hepatic sinusoids. These are areas where you have an extreme exposure of blood coming from the absorptive surfaces of the small intestine. And because of the potential danger of something coming in from your gut into your bloodstream, there's going to be phagocytes called Kupffer cells that are sitting around these sinusoids waiting to snatch out anything that does not belong there. So here we have a depiction of the three capillary types, and you've got the continuous capillary, most common type that we have in our body, fenestrated type, in which you actually have the holes in the cells themselves, and then the sinusoidal, they refer to it here as discontinuous. We use the word sinusoidal. These actually have the gaps between the cells. This is a depiction of a capillary bed, and sometimes you'll see the phrase plexus or network of the capillaries. And all they're talking about is you have the arterial side, and then you have the venous side. Between those two sides, you have this connection of capillaries, and the division in real life is not so distinctly demarcated. If I had my way, I would probably make this entire area sort of a various shade of purple to show that this is a gradual switchover between fluid being carried outward. Oops, let me put my pencil back on. Fluid being carried outward by the hydrostatic pressure, or the blood pressure. And that pressure is going to get smaller and smaller and dissipate until suddenly it cannot overcome the blood colloid osmotic pressure, which is actually going to be now putting fluid back in there. So that is the blood colloid osmotic pressure. Remember, colloid simply means a large organic molecule, in which case we're now talking about plasma proteins. So there's going to be a gradual switch over. There's not a perfect line of demarcation, but just they do this in the red and blue just to make you understand you actually have an arterial side of the capillary bed and a venous side of the capillary bed. And again, it's talking about direction of flow. Just wanted to take a moment and talk about some safety mechanisms that your body has put into developing these vessel systems. Something called the collateral circulation. This is when you have multiple arteries going to the same area. In this case, we're talking about a capillary bed. I always picture this. Let's say you're going to Manassas from here. You could go at 29, but if there's a wreck on 29, then you could go at 28, or you could go from Warrenton, you could go to 17, then 15 to 66. So that you have multiple ways you could get there in case one way was occluded. And that's what your body is doing. It's saying, hey, if we have a blockage here, some sort of vascular damage, we have other ways of supplying nutrition and oxygen to that area. So sometimes your body will actually produce new blood vessels because it sees the need. I'll give you an example. Let's say that you've got a blockage in your heart muscle that is going to cause an area of decreased perfusions or ischemia. If you're not having any sort of impending medical disaster here, if it's causing just a low-grade level of blockage, you might be conservatively treated until your body can actually grow new vessels into that area. So the term anastomosis is when these arteries are actually fused, and my example for that was always going to be, think of the Capitol Beltway, 495 surrounding Washington, D.C., so there are several ways to hop off and go into the city. If one exit's blocked, you simply take another exit. So every now and then you'll see something called an arteriovenous anastomosis, and that's when the arteriole is going to feed directly into the venule, and it does not allow the blood flow through the capillary bed. An extremely important anastomosis here in your body is going to be something called the circle of Willis. This is at the base of the brain, so this is in this area right here, the spinal cord. So picture you looking from under your chin upward, and this vessel is called the circle of Willis, and it is an anastomosis. It is actually joining the basilar artery, which comes off the vertebral arteries, and the internal carotid and middle cerebral, which come off the external carotid vessels. So what you've got, if you have a blockage in this area, for example, you've still got blood that can flow around to that area. Not always a perfect system, but I'm sure it has saved many people that we're totally unaware of. We're going to switch gears for just a moment and talk about the phenomena of vasomotion. Vasomotion refers to the body's ability to control blood flow, either increasing it or decreasing it to a certain area. It's the ability to raise blood pressure and lower blood pressure, totally independent of heart contraction. So you'll see this referred to sometimes as an oscillation of these blood vessels. So this is a very quick, very effective way for the body to control blood pressure and also to respond to changes in blood pressure. This is handled for the precapillary by the precapillary sphincters that we talked about that were on the arterioles. So if these capillaries tighten up, it's going to increase blood pressure and shift blood flow to a different area. So understand the concept that if the blood vessels dilate, it's going to let more blood flow into widespread capillary areas, and so it's going to decrease the general blood pressure. However, if the body wants to increase blood pressure, it's going to vasoconstrict and tighten up these little precapillary sphincters. The body has three ways of controlling vasomotion. We're going to look at some of these, not necessarily in this order: hormonal control, neural control, and local control. And we're going to be talking about the neural or nervous system control first. You have an interoceptor in your body referred to as a baroreceptor. These are the receptors that pick up changes in blood pressure. For example, if you have a sudden increase in blood pressure, then your body is going to respond by decreasing the sympathetic tone. In other words, it's going to allow a vasodilation to ease off the impending damage caused by high blood pressure. On the flip side of that, if you have sudden blood pressure drop, let's say you've had a sudden hemorrhage, what's going to happen then is your body is going to decrease a parasympathetic tone, increase a sympathetic tone to cause a vasoconstriction to increase your blood pressure. So these baroreceptors sit in these little dilations referred to as the carotid and aortic sinuses. They pick up the blood pressure, and if they need to adjust something, then you're going to have neurons carrying this information to the brainstem, and then the brainstem will instruct the body what to do as far as vasoconstriction, vasodilation, in order to control whatever dilemma your body is perceiving. So to look at the hormonal control of vasomotion, let's start with these hormones: angiotensin, aldosterone, and antidiuretic hormone, or ADH. The kidney produces a hormone called renin, and there's a conversion process that goes into angiotensin 1 and 2 from the renin, and these are all processes that take place in the lung and liver. We'll deal with that more later. But then the angiotensin is going to cause the kidney to retain sodium. Aldosterone is it's actually a mineralocorticoid hormone that's secreted by the adrenal cortex. And then finally, the antidiuretic hormone is secreted by the hypothalamus, that's produced in the pituitary. All of these hormones manipulate the sodium. So a little phrase I'll tell you now, and you need to keep this in mind throughout the rest of the course: water follows salt. And we use the word salt to indicate sodium. most of the salt that we consume is in the form of table salt or sodium chloride. So if your body wants to increase the blood pressure, it's going to increase the amount of sodium that it takes out of your urine filtrate. So you're going to keep it. And then that means that you're going to keep more fluid that's going to come back into your body. You'll urinate out less. So angiotensin, aldosterone, and ADH, you need to know that these will increase blood pressure by increasing your sodium reabsorption. And these have their effect at the level of the kidney. We'll talk about these hormones more in depth later. This is in contrast to the sodium savers. The next pair of hormones that you need to know, something called ANP and BNP. Atrial and brain natriuretic peptide. Now, even though the word brain is thrown in here, I want you to make sure that you know that these hormones are both manufactured in cardiomyocytes in the heart, in the right atrium, as a matter of fact. So the word peptide is simply meaning a small piece of a protein, so don't get hung up on that. Natrium is Latin for sodium. Uresis means to urinate, so natriuresis would be to urinate out sodium. So these hormones are your sodium losers. The ones we talked about earlier were your sodium savers. So if you have an increased blood volume coming to your right atrium, it's going to actually stretch the muscle of that right atrium. That's going to cause release of the ANP and BNP. That's going to cause you to excrete more sodium at the level of your kidneys, and water follows salt, and now you urinate out more fluid, and that will decrease your blood volume. And then the final method of control of vasomotion is going to be at the local area, autoregulation. So in other words, if you have an area of tissue or you have an area of lung that you need more oxygen, you'll actually have a vasodilation in that area in an attempt to try to get more blood flowing through there to bring more oxygen to that area. You might have a local area of vasoconstriction if your body's trying to deal with blood loss or some sort of toxic effect, say a wasp bite or something like that. Okay, let's move over to the other side of the vessel spectrum here and talk about veins. You need to know that veins are known as capacitance vessels. The word capacitance means stretchiness. Don't get this confused with elasticity. Elasticity is more bouncy. This is simply more stretch. So large veins have all three layers of intima, the media, and externa. And make sure you know that the largest veins in the body are the inferior and superior vena cava. Just like it sounds, the inferior vena cava is bringing blood from the lower part of the body, superior from the top part of the body. So medium veins will have a thinner tunica media, and you'll have fewer muscle cells there, and the tunica externa has more elastic fibers. And then the medium veins branch out into the smaller veins called venules. I mentioned to you earlier on in this lecture that by the time you've crossed that capillary bed, you've lost the advantage of blood pressure that's going to return your blood volume to the heart. And it's got to go. Think about it, if you're standing up, that blood is flowing to your heart going against gravity, and there's not much blood pressure to take it up there. So some mechanisms you've got to make sure the blood does get there is you actually have valves in your veins. These are very simple little flaps of tunica media. So right here, this is representing a valve. Now, as you walk, your muscles are actually massaging those veins, and that massage effect is pushing the blood flow back up toward the heart. And then the other mechanism of returning that blood to the heart is going to be something called the respiratory pump. In the next chapter, when we start talking about respiration, you're going to see that when you contract your diaphragm and contract your intercostal muscles to breathe inward, you're going to be increasing the internal volume of your thoracic cavity. That's actually creating a vacuum. It's creating a negative pressure. That vacuum is going to help pull blood back to the heart. So that's referred to as a respiratory pump because it happens as you breathe. So be familiar with these three mechanisms of ensuring blood return to the heart. So just one more note I'll make about the muscular massage, the compression of the veins by the muscles. It just so happens there are some animals that don't have valves in their veins, and horses are one of them. So if you're a horse person, you'll know that if you let a horse stand around in the stall and not get out and move around, for example, let's say you're trying to protect them from snow, which horses like snow. I always hated to see horses kept in the stall because it's snowing outside. But when they stand, they've got no movement, no compression in their feet, and something called a frog. The frog is sort of a spongy structure on the bottom of their foot, and the frog is what pushes that blood back up to the heart when they walk. But if they're standing still, there's no push from that frog, and so the blood sort of settles down, and horse people refer to it as being stocked up, but basically all four legs were simply swollen, and you fix it by turning the horse out and letting them get some exercise. The same principle happens for us. If our veins happen to be less than perfect, or if you're on a really, for example, a long airplane flight and you're not moving around, you don't have that massage of those muscles to help return that blood, and so you'll end up with swollen feet. In fact, we'll talk about a little bit shortly about deep vein thrombosis and the importance of moving around during long trips. I put this slide in here simply talking about varicose veins. We've all heard that term. And so varicose veins happen when the valves are damaged because they get stretched out. This can happen due to people who stand on their feet all the time, such as professors or teachers, people who walk a beat, such as mail delivery people, policemen. So they simply, from being on the feet all the time, tend to wear out these vessels. The problem then is that people tend to swell. You can end up with a complication called phlebitis. That's spelled a PHL, by the way, phlebitis. It means inflammation of the veins, and you can actually start getting into all sorts of blood clots. So they make compression hosiery to try to prevent this from happening. There are a lot of procedures where they go in there and strip the endothelium out of these vessels and make them collapse. They actually have procedures where they'll actually inject something into the vessel to cause it to collapse, and that makes for a cosmetic effect, but unless you're really careful, you'll have more vessels forming and enlarging, so it's sort of a whack-a-mole procedure unless you're going to really control your lifestyle. Just a note here, if you think about it, your veins are much stretchier. They have a little bit more give than what your arteries are going to have. So therefore, you've got most of your blood at any given time is on the venous side of your circulation. You actually have what they refer to as a venous reserve, and most of that's actually in your spleen, but also your liver, bone marrow, and skin. So if you have a major hemorrhage, one of the first things that's going to happen is that your spleen is going to contract and give you what they refer to as an autotransfusion, where you push these extra blood cells into your vessels in an attempt to keep blood flowing. If you think about it, if you have some sort of major hemorrhage, you're going to be frightened, and possibly a great deal of pain. This is going to activate your sympathetic nervous system. Remember the fight, fright, and flight part of your autonomic system. And that's going to cause a systemic venoconstriction. In other words, those veins are going to constrict, trying to increase your overall blood pressure to keep you from going into cardiovascular collapse, and that's what causes your spleen to contract and your liver and all these other reserves to push their blood cells back into the circulation. Anytime you see the word dynamics, it's simply talking about the phenomena of movement. We'll talk about respiratory dynamics. We've already talked about cardiodynamics when we were talking about stroke volume, cardiac output. Let's talk a little bit about vasomotion dynamics here. First thing to think about, the simple concept, all the blood that comes out of your capillary beds is going to have to be equal to the amount of blood that comes out of your heart. So total capillary flow is going to be equal to cardiac output. So a couple of measurements here. One's going to be pressure. The heart has to have enough pressure to overcome resistance. Flow is proportional to the pressure gradient and inversely proportional to resistance. So to put this into an equation then, flow is proportional to the pressure, but inversely proportional to resistance. So the higher the pressure, the higher the flow. Very simple. Then on the inverse part, the higher the resistance, the lower the flow. The more resistance, the less flow you're going to have. So you have to have enough pressure, you have to have enough flow in a positive portion that's going to be greater than the amount of resistance. Otherwise, your blood flow stops and you go into cardiovascular collapse. So everything we've talked about, all the vasomotion, everything we've talked about, cardiodynamics, that is all intended to keep this happening. Pressure has to be great enough to overcome peripheral resistance, or otherwise your blood vessels will simply stop functioning, your blood will stop moving, and you go into cardiovascular shock. A few things to think about contributing to total peripheral resistance, and I always use the example of a water hose here. If you were to try to just picture a water hose instead of a blood vessel. So picture if you were to have a water hose with a really wide diameter. If you were to go buy the cheapest little tiny water hose you could get, you would know that when you hook it up to the hydrant, you're not going to have a huge amount of force. This is why fire hoses have this huge diameter so it can blast. I mean, a fire hose will literally take the paint off a wall. It'll actually disassemble a wall. So the bigger the diameter, the more pressure you're going to have. Okay, lengthwise, if you have a water hose that's 100 feet versus one that's 6 feet, you're going to have a lot less pressure out of the long one than you will the short one. If you picture a column of water going through a water hose or a column of blood going through a blood vessel, there's going to be friction between the molecules of that column and the molecules of the lining of that vessel or lining of that water hose. Anytime you have friction, you create resistance. Now, if you have a wide diameter, that means you have a whole central column that's not going to be in contact with the wall, so you've got less resistance. With a length, if you've got a really long length, you're markedly increasing the amount of resistance in that vessel or in that water hose. If you've ever had to find a cord to plug in something heavy duty, such as a washer, dryer, oven, refrigerator, you'll see that you have to have a really, really thick, short cord. They tell you, in fact, a lot of things, you're not even supposed to use an extension cord. The longer it is and the more narrow it is, the more resistance you get to whatever flow that's going to be, flow of water, blood, or even electricity. And then looking at blood viscosity, this will make sense if you picture it. Let's say you're taking this piece of water hose and you put water down it, and then the next time you put something thicker like syrup. Obviously the syrup's going to move much slower. So the thicker the substance or thicker the blood, the more resistance you're going to have. And then also turbulence. Picture that water hose if you put gravel or sand into it. It's going to interfere with the flow of water through that hose. So same thing as if you have a blood vessel and you've got arterial plaque built up, then as your blood flows through, you're going to be creating turbulence and not as much blood can go through with little resistance. So understand the four concepts that would increase resistance. So to, I guess, think about it from the flip side, your least resistance is going to be a wider vessel, a shorter vessel, with decreased blood viscosity and no turbulence. Switching gears here, let's just mention blood pressure. We've all talked about our blood pressure at some point in our lives. Blood pressure is a measure of your maximum or peak systolic pressure divided by your minimum diastolic pressure. And remember, the systole, heart contraction, diastole, heart relaxation. So your maximum, the highest goes on top of the lowest it goes. So the pulse, what you're feeling when you're actually palpating a pulse, is the pressure difference between those two numbers. So traditionally, they used to think that 120/80 was the ideal blood pressure. They now actually think it should be lower. It's going to vary from person to person, age, gender. Typically, when you're much younger, it will start out pretty low. In fact, I remember when I was in my 20s, I'd have blood pressures of like 90/60 something. And I would love to have that blood pressure now. It's just that as you age, your blood vessels get a little bit more rigid, and you create a little bit more afterload for your heart. So hypertension and hypotension are obviously high blood pressure and low blood pressure, so be familiar with those terms. And blood pressure, when you have your blood pressure measured, is simply a picture at one given time of the day. Your blood pressure typically is made a little bit higher in the morning when you first wake up. It should be a little bit lower in the evening. It's going to depend on your caffeine intake. To get an accurate measurement, you actually have to wear a halter with a monitor that's going to keep up with it and average it out. There's a lot of people that have what they call a white coat syndrome, where they're a little bit more nervous, a little bit more tense every time they go into a physician's office and get it measured. And people for years thought that really was pretty insignificant. Now I've seen studies talking about the people who have the so-called white coat syndrome. Quite often that may be a sign of an underlying issue. So it's not just an innocuous event. By the way, we've all seen the little wrist cuffs that people use to measure blood pressure. They do the job to some degree, but if you want something more accurate, you're going to have to get the kind that goes up around the upper arm. The reason hypertension is such a killer, it's going to cause an increase in the afterload. So the heart's going to have to work that much harder, especially on the side of the left ventricle. If it's going to work harder, the myocardium that is, then it's going to take more oxygen. That's going to end up resulting in what they refer to as myocardial ischemia. You should remember the word ischemia simply means reduction in oxygen, reduction in perfusion. Perfusion simply means the amount of circulation in that area. And if the ischemia is not corrected, it's going to result in the death of that piece of myocardium, that piece of heart muscle, and that dead area is going to be known as an infarct. So myocardial infarction now is going to be death of cardiac muscle tissue. That's what a heart attack is called, a MI, myocardial infarction. I'm sure you've seen people on television shows and that sort of thing. They grasp their chest, sudden pain. The cardiac or chest pain is referred to as angina. So I'll put the word up here, angina simply means chest pain. Quite often that may be caused by spasms in cardiac blood vessels, and they treat themselves with a sublingual capsule of nitroglycerin. Nitroglycerin, if you remember, is a vasodilator, and that relaxes the blood vessels in the heart and takes away the pain. So the classic clutching of the chest and left arm pain, please understand that is something that's not always seen, especially in women. That's more of a male type presentation. It might be jaw pain, it might be neck pain. With women, sometimes it's just sweating and nausea. There have been women who had a heart attack that the first indication was they started throwing up. And they've actually recently discovered that the actual vessels that are occluded in a heart attack will vary sometimes for men and women. Men tend to have occlusion of larger vessels, and they have that sudden classic onset of a heart attack, whereas with women, it's more of an obstruction of what they refer to as microvessels, little tiny vessels, and sometimes it doesn't show up on an MRI or some sort of diagnostic procedure, and that's why sometimes women can have multiple heart attacks before they're actually, if they're ever actually diagnosed. So talking about blood pressure here, and I apologize, I see some compression on my slide that's caused by this app that I'm using to put this online. But it's talking about blood pressure leaving the left ventricle into the aorta. That's going to be the highest pressure in the body. The vessels, those arteries, have what they refer to as an elastic rebound. This elastic rebound is that stretchiness produced by the bounce of that shooting of that hard blood flow, and it stretches and then it recoils, and this bounciness helps push the blood on through the entire system even when the heart itself has ceased to contract. So remember, the further away you get from the heart, the pressure is going to decrease, and by the time you get to the venules, you'll actually see the blood pressure is only 10% of what is actually produced by the heart and the aorta. And that's why veins have a large diameter, but so they'll have a low resistance. So the only thing that's going to help get that blood flow back up to the heart is, like we talked about earlier, that respiratory pump and that muscular massage or muscular contraction that's going to help push the blood upwards. So if you consider the importance of that elastic rebound, think about what would happen if we have atherosclerosis or arteriosclerosis, old term maybe hardening of the arteries. You'll actually get calcium plaque built up in some of these arterial walls. As you can imagine, that takes away this bounciness, this elasticity that's so important. And that's going to really markedly increase the afterload, increase the amount of work that the heart's going to have to do. So, just in retrospect, looking back over what we've talked about, understand the importance of the elasticity, the bounciness of the arteries, and the capacitance or the stretchiness of the veins. Okay, let's talk about then what happens at the level of the capillary. Now, we've discussed this before, but I really want to go into it in some detail here. We even started discussing this way back in chapter 3 when we started talking about diffusion and osmosis. Remember, diffusion is a passive transport system, and it happens naturally. It happens with no forces, no energy, no ATP is being burned here. It always goes down a concentration gradient. Remember, a concentration gradient is when you've got a difference of concentration. You've got higher on one side and lower on the other. So diffusion is simply nature's way of correcting that gradient. It's going to try to equalize us out. Now, if you add pressure to that diffusion, you're going to be talking about filtration. So filtration pressure is going to be called hydrostatic pressure, and in our case, we're going to be talking about blood pressure. So make sure you know you need to equate filtration, hydrostatic pressure, and blood pressure. That is going to be pushing fluid and the solutes that are going to be dissolved in there out of the blood vessels. Now, that fluid is going to have to come back into the blood vessel, and so for that, you're going to use blood colloid osmotic pressure, BCOP. So that's going to be drawing fluid back in. So BCOP, you need to know, is created by plasma proteins. Remember that these capillary walls are so thin that fluids and ions, these really small molecules, and things that are diffusible, things that are soluble in lipids, will move back and forth very freely. Plasma proteins are too big. So under a normal situation, plasma proteins are going to be trapped inside the blood vessel walls. And that's a fortunate thing because that's what's going to be giving us that blood colloid osmotic pressure. In case you've forgotten, and this is an important concept, the biggest, most important difference between the content of interstitial fluid and plasma is that plasma has the plasma proteins. I know you guys look at these formulas and your eyes kind of cross, but this is pretty simple if you think about it. And I went ahead and bypassed a step that your book talks about. I'm going to go ahead and just talk about net, meaning overall, because for every force, there is going to be a tiny amount of opposing force. In other words, for a hydrostatic pressure pushing fluid out of a vessel, you're going to have a tiny amount of going in the opposite direction. What matters is the overall sum, or the overall net. So net filtration pressure equals the net hydrostatic pressure minus the net colloid osmotic pressure. So if you end up with this number being too small or this number being too big, you're not going to have enough blood flow in your vessels. You go into cardiovascular shock or cardiovascular collapse. So we'll be talking about a little bit more later on, talking about the lymphatic system. That's chapter 22. You'll see that we have this system. We draw a crude little blood vessel, and again, I'm drawing with my finger, so I'm not the best artist in the world on a good day, but with my finger it makes it a little bit worse. You've got your heart down here. Ooh, that was a bad one. And you're pushing fluid out of the vessels. That's going to cause an increase in concentration of the plasma proteins. And then you're going to finally reach a point where the hydrostatic pressure is going to be overcome by the net colloid osmotic pressure because of the concentration change. And now your BCOP is going to be pulling fluid back into the blood vessels. So what it's doing here is dropping off oxygen, is dropping off nutrition. Here it's carrying back with it carbon dioxide and waste. Can't get my 2 on that oxygen over there, but anyway, let's put it over this side to be complete. Carrying the waste tissue back into the blood vessels so it can be dumped out in the lungs and dumped out at the level of the kidneys. Now, this is not a perfect system, so not every amount of fluid is going to be picked up, and the remainder is going to be picked up by the lymphatic vessels, and we'll talk about that later. That extra fluid is going to be dumped back into the venous system, but it's going to be scavenged out by the lymphatic vessels. So these next slides are just some graphics that I picked up to try to get you to think about. Okay, again, you got your heart. The blood pressure itself is going to be translated into hydrostatic pressure, filtration pressure. It's going to be pushing, if we're at the capillary level, fluid out. It's going to be carrying with it oxygen from the lungs, amino acids, glucose, nutrition from the gut, some fatty acids, things to supply the cells with what they need for their daily activity. And then on the flip side of that, you're going to have osmotic pressure that's going to be drawing fluid back into the capillary, and it's going to be taking with it waste and carbon dioxide. And so this next slide I've got is going to show you just another graphic. I think we've got this, it's maybe from your textbook, but again, you've got the arterial side and you've got the venous side. So here you're giving stuff to the cells, you're putting it into the interstitial fluid, then it's going into the cells, and here you're actually taking waste products and going back into the blood vessels, and then this will go back to the lungs and the kidneys to be cleaned up again. So anyway, this is a very important concept. It doesn't matter to me what graphic you need to kind of work your way through this. Your book has several, but this is a very important concept to understand. And I want you to think about what happens when things go wrong. If you have a loss of plasma proteins, if you have a loss of blood pressure, what effect is that going to have on the amount of fluid that's being pushed out of those vessels or reabsorbed into those blood vessels? And now you have things like congestive heart failure. You might have liver failure. You're not making enough proteins. You might have a protein-losing enteropathy where you're losing protein through your intestinal tract, or glomerulonephritis where you're urinating out a lot of protein which you shouldn't be. All these things are going to affect these fluid dynamics. So if you think about the formula of net filtration pressure is equal to your hydrostatic pressure minus a blood colloid osmotic pressure. Now let's look at what can go wrong. If you have a major hemorrhage to the point that you've decreased your blood volume, so therefore you've decreased your blood pressure, what's going to happen is you're going to end up with a decrease here. That decrease is going to be resulting in a decrease of the net filtration pressure. So the blood color osmotic pressure now is going to be a little bit overwhelming to the hydrostatic pressure, and that means that you're going to be drawing more fluid into your capillaries from the interstitial fluid. So that's the way your body uses to try to overcome the significance of the blood loss. Again, your body is trying to keep its blood vessels open at all times, because when they collapse, when the flow stops, then that's going to be a fatal event. So to get rid of this right here, we're going to end up with an increase in the blood colloid osmotic pressure. So now let's think about it. What happens if you're dehydrated? That's going to end up meaning an increase in the concentration of your blood colloid osmotic pressure, because again you've lost the fluid here. So your BCOP, repair that there, is going to increase. And what you're doing is you're drawing fluid from the cells, from the interstitium, into the blood vessels, trying to keep, again, your blood vessels open. Now, obviously, it's not a desirable thing to dehydrate your cells, but that is a mechanism to try to keep you alive. So now think about it from another standpoint. What happens if you have high blood pressure? Then you're going to end up with more fluid being pushed out than what you really wanted to, and you're going to end up with something called edema. Edema, by definition, is simply excess fluid in the interstitium. So high blood pressure will cause people's feet to swell, legs to swell. If you have a loss of BCOP because you have liver failure, so your liver is not producing proteins, as I mentioned in the last slide, or you've lost proteins, then you don't have enough BCOP to pull fluid back into the vessels. So again, you have edema. So think about what causes edema. Too much hydrostatic pressure or too little BCOP? Think about what happens, let's go back up here, with dehydration. Think about what happens with hemorrhage. So work your way through that using this equation. I mentioned earlier the term perfusion. Perfusion simply means the blood flow through the tissues. All sorts of things that can affect this. Is your heart producing enough output? Do you have too much peripheral resistance? In other words, do you have vessel damage? Do you have atherosclerosis? Do you have inadequate blood pressure? Lack of perfusion, make sure you know the word ischemia. And then we've already talked about mechanisms of controlling perfusion earlier when we talked about vasomotion. We talked about the hormones. We mentioned autoregulation. And then we also talked about neurologic regulation of vasomotion. To talk about the local control that we started to talk about earlier, but we did not go any further into it, these things will cause a vasodilation. So when your body recognizes a low oxygen content, an accumulation of too much carbon dioxide, a presence of nitric acid, anything, in fact, think about, I've told you before, hydrogen. When you say hydrogen, they're talking about protons, or talking about acids. So anything that's acidic, anything that causes inflammation, you're going to have vasodilation. In fact, if you remember the cardinal signs of inflammation, redness, swelling, pain, loss of function is included by some textbooks. We didn't really include that one in there. But rubor, calor, dolor, and tumor. And that rubor is redness, and that tumor is going to be the swelling. And this is both happening because of vasodilation in that area. If you have injury to tissue, damaged cells are going to release chemicals referred to as prostaglandins and thromboxanes. A lot of the painkillers, a lot of the antiarthritic medications, this sort of thing, they're antiprostaglandins, to give you an example. These will act to constrict the precapillary sphincters that you see in the arterioles, metarterioles. So what they're trying to do is restrict blood flow to that area, to stop hemorrhaging and to also maybe stop the spread of toxic material to other parts of the body. So not only does your body have a way of local vasodilation, but it's also got methods to locally vasoconstrict. And we mentioned the endocrine changes. Those take a little bit longer. We talked about, remember, the BNP and AMP and the ADH. We talked about aldosterone, angiotensin systems. We also mentioned that the nervous system has a way of controlling it. And I wanted to bring this up again to point out a couple of centers in your brainstem. Instead of having one center, you actually have a couple of different centers that sort of have a balancing act between them, the cardioinhibitory center and the cardioacceleratory center. And they have, again, sort of a teeter-totter effect here. They try to balance each other out. Same thing with the vasomotor center. They're going to have the sympathetic system that's going to be balancing with the parasympathetic system. So I've already discussed this, so I'm not going to linger too long here. I had given you the description of baroreceptors, where they're located, and there are also some in the right atrium. So if you have increasing blood pressure, this goes actually back, let me go ahead and write this for you. Cardiac output is equal to stroke volume times heart rate. So if you have an increase in blood pressure, your body is going to try to mitigate that by decreasing your cardiac output and also with a peripheral vasodilation. Now, if you have a decreasing blood pressure, then your body is going to respond by increasing your heart rate to increase cardiac output. Peripherally, you're going to have a vasoconstriction trying to drive that blood pressure back up. And again, if we talk about this on a long-term basis, we'll start talking about the endocrine hormonal changes again, but just talking about these reflexes that will happen in a matter of seconds to minutes. So these reflexes are responding not only to baroreceptors, they're responding to another type of endocrine receptor called a chemoreceptor. These are responding to oxygen, but even more important, they're responding to CO2. You would think it'd be oxygen most importantly, but they seem to be more sensitive to elevations of CO2. And also you have chemoreceptors that are going to be picking up acidosis or pH changes. So these, again, they're going to be feeding information to the medulla oblongata and the brainstem. And if your body picks up the fact that you've got a decreasing O2 level, increasing CO2, you're going to be having effects as far as your respiratory centers and blood flow to your brain. See, the problem is, what we've been talking about now are reflexes. These are things under control of the autonomic nervous system. So if you recall back to neurology, we talked about first, second, and third order neurons. For you to be aware of something, you've got to have a third order neuron that's going to be ending up synapsing on other neurons in your cerebral cortex. For these reflexes, they don't go that high. They're going to stop in the level of the midbrain and brainstem. And so, unfortunately, you're not going to be aware of the fact that you're having a low oxygen, a high CO2. You're not going to be aware of the fact that your blood pressure is too high, your blood pressure is too low. So the reason I'm mentioning this now is you've, I'm sure, heard blood pressure being referred to as a silent killer. If we had ways of knowing that our blood pressure was too high, if we had ways of knowing that our oxygen level was too low, if we could recognize this by a thought process, other than just maybe, oh gee, I just don't feel good today, we might be able to counteract an impending heart attack or an impending stroke. Now, just to review for your exam, we talked about some endocrine control systems of the vasomotion and blood pressure, antidiuretic hormone, angiotensin, aldosterone. And to counteract those, for the opposite effect, you're going to have ANP and BNP, and then we'll talk about EPO in just a moment. So just remember, these are the sodium savers: antidiuretic hormone, angiotensin, and aldosterone. We'll talk about more exact mechanisms in later chapters, but these cause you to take sodium out of the fluid that's going to eventually become urine. So you're sodium saving. This causes you to retain water, and this will increase your blood volume and blood pressure. The natriuretic peptides, remember I told you that natrium is Latin for sodium. Uresis means to urinate. So natriuretic means you're going to urinate out sodium, which means you're going to urinate out more water, which means you're going to lower your blood volume. So atrial and brain natriuretic peptides. You release these from the muscle of your right atrium because it's been stretched due to excessive blood return to the heart. These are your sodium losers. So erythropoietin, we've already talked about this in chapter 19. It's a hormone that's released by the kidney, and it stimulates the bone marrow to produce more red blood cells. So you'll have this on a long-term basis. Again, anything endocrine is going to typically take a lot longer than any of the neural control mechanisms. But let's say you move to the Swiss Alps, or you move to just basically a high altitude area for a long period of time. Your body's going to be responding to the fact that the concentration of oxygen in the atmosphere is lower, and so there's less diffusion of oxygen across your pulmonary membranes, and so you need more red blood cells to try to carry a little bit more. So if you have a long-term response to a major hemorrhage, let's say you've lost a high proportion of your blood flow, you're recovering from that, and so your kidneys are going to release erythropoietin in order to kind of rev up your bone marrow, put it in a little bit high gear. You may recall we talked about this in terms of EPO, which is a medication that's supposed to stimulate or simulate erythropoietin. They use it in cancer patients, and athletes also use it to quote-unquote dope to try to increase their endurance levels. So we talked about Lance Armstrong and his experience with this. Okay, so switching gears again, just a few more things I want to mention here. We talked about this a little bit in chapter 20. When you are lightly exercising, and then I say light exercise is in the normal amount of exercise that one might do if they're not an extreme athlete, you're going to end up with a vasodilation in your skeletal muscles because you're increasing the blood flow to them to help them do the work more. At the same time, you're also having a large increase in your muscular contractions, so that's going to increase the amount of blood being brought back to your heart. So basically you've increased your cardiac output. So imagine exercising and now your heart is beating harder. Remember this, the Frank Starling effect. If you have an increased stretch of the myocardium, it's going to beat harder, and it's going to also be beating faster, increasing your cardiac output to compensate for that vasodilation. Now let's say you're moving into some really, really strenuous exercise. You can actually activate your sympathetic nervous system. So here you've got maximum cardiac output. You're going to actually decrease the amount of blood that's flowing to your digestive tract, and you're going to be increasing the amount of blood to your skeletal muscle again, and also heart and lungs. So if you've ever seen, for example, somebody in some sort of extreme athletic event, marathon, a race, something I can't personally relate to at all, but you'll actually see them stop and throw up. And the body is saying, hey, I don't want to deal with thinking about digesting that spaghetti you carb loaded on last night, so I'm going to go ahead and throw it up. Overall, remember all of these processes that are happening with your heart, your blood vessels, they're trying to maintain the blood flow to the brain at a normal, steady level. We've talked about vasodilation to muscles, we've talked about vasoconstrictions to GI tracts, that sort of thing, but your body will never vasoconstrict anything going to the brain. Your body must keep blood flow to the brain at a normal level. In fact, if something happens and your body is sensing a decrease in blood flow to the brain, you will actually faint. You lay down horizontally when you pass out, and that means that the gravity is no longer opposing blood flow to the upper part of the body to the brain, and that's your body's way of trying to compensate for that sudden drop in blood pressure to the brain. Now, I told you in the earlier slides to be prepared to think your way through what happens when things go wrong with blood pressure and blood flow. Just going to walk you through a few examples here. What happens when you have a major hemorrhage? You have the baroreceptors in your carotid and aortic sinuses are going to be picking up the decreased blood volume, and that's going to cause your heart rate to go up in order to increase your cardiac output, because again, cardiac output to the brain has to be stable. The other thing that's going to be increasing this is that your sympathetic system is going to be kicking up your heart rate too. Peripherally, you're going to vasoconstrict. And then on a long-term basis, epinephrine, norepinephrine, angiotensin, ADH, and EPO will all help correct that decrease in blood volume. Just to try to make my abbreviations clear, again, cardiac output, heart rate, sympathetic nervous system, epinephrine, norepinephrine, antidiuretic hormone, and erythropoietin. So take this slide if you don't understand it and go back to the preceding slides, go to your book, whatever resource you're using, and understand the cardiovascular response to hemorrhage. What your body is trying to do when it responds to hemorrhage is to prevent shock. Shock results when you've lost more than 20% of your total blood volume. You'll see a weak, thready pulse and pale, clammy skin in a shock victim. Typically what you're going to do is elevate their feet, trying to maintain blood flow to the brain, and also try to cover them up, warm them up some. If this is not corrected, if shock is severe enough, then again what's happening is you're not having enough blood flow to keep the blood vessels open, and you have cardiovascular collapse and death. We make it sound pretty simple. I went ahead and threw this slide in here. You don't have to regurgitate anything off this slide back on the exam, but if you look over this this slide, what you're going to be seeing is breaking it down to smaller pieces here. If you've got lack of blood flow to an area as an inadequate perfusion, the cells don't get enough oxygen. If you don't get enough oxygen, you can't make enough ATP. That means the cell is going to be switching from oxidative phosphorylation into glycolysis. It's going to cause you to accumulate lactic acid. Lactic acid itself is damaging. You can end up with metabolic acidosis, and that's going to cause your body to try to compensate with vasoconstriction. You end up with all these damages here. If you look at this peripheral pooling of blood, your sodium potassium exchange pump is not functioning here. You've got breakdown of the walls of the lysosomes. That's going to release all these really toxic substances that enters the circulation. It ruins your epithelium, and you end up with cell death, disseminated intravascular coagulation, and all these nasty things. I guess while we're talking about nasty things that can happen to you, let's go ahead and talk about stroke. A cerebrovascular accident, CVA, is another name for a stroke. You may hear the term TIA, that'd be the little mini strokes, little transient ischemic events. But what we have here for strokes, we have two major types, ischemic and hemorrhagic. An ischemic stroke, they're the most common type. That happens when you have a blood clot that may come from plaque in the carotid artery, could come from the heart, any other place in the body. It lodges into one of the arteries in the brain. You might, in fact, one of the most common ones would be the middle cerebral. You might end up losing function of, for example, facial muscles. If it affects Broca's area, you might not be able to articulate, you might not be able to speak. If it affects Wernicke's area, you might not be able to comprehend. It might affect an entire one side of your body. Remember that if you have a lesion on the right side of your brain, it's going to affect the left side of your body and vice versa. Now, there is some variability as far as location of the speech and comprehension areas, depending if you're right-handed or left-handed. Of course, most people are right-handed, so there's some pretty broad generalizations you can make there, but they're not always perfect. The effect of the stroke might be something that can be survived, and quite often people can heal. Sometimes they don't heal all the way. Sometimes they do. So, just to mention the other type of stroke, hemorrhagic, is where it's not due to a blood clot, but it's actually due, you can think of it as a brain bleed. So you'll see this in older people more often. Now, obviously, if you present to an emergency room, you're going to have to be able to tell which one of these is happening, because the treatment is obviously for a blood clot is going to be very different from what you would treat with a free bleed. So they'll go ahead and do a very quick neurologic exam evaluation and then a CAT scan or MRI to try to figure out what's going on. The period of time to successfully treat a stroke and to minimize the amount of damage is critical. So if you think someone's having a stroke, they have to get to the emergency room immediately. There's a saying that time is tissue, and the more delay there is between the time of event and time of treatment, the potentially more devastating the outcome can be. Just to give you a couple of definitions, you had these in 141, but I wanted to make sure you were up on your terminology here. A thrombus is a stationary clot. An embolism is a thrombus that has moved. So you can start out, for example, with a blood clot in the veins of your leg. And then when you get up and move around, you've gotten off that airplane, that blood clot can now go to your lungs, it can go to your brain, it can go anywhere and cause a totally different scenario than what it would have caused had it stayed still. Just wanted to mention one scenario here. I've alluded to it several times. It's called deep vein thrombosis. And this is more of a danger than most people realize. People think about it as something that is a problem on international flights. It can happen on any time, be it in a car, airplane, whatever, where you're sitting still for more than 3 hours at a time. So even on long car rides, you should actually get out, move around, stand up, wiggle around, at least more than every 3 hours. I had a professor when I was in college that after I graduated, he was coming up here for a business meeting, and he got off an airplane, got to the hotel lobby, and he fell dead. And they theorized that was a deep vein thrombosis. He was overweight. I believe he was probably also a smoker. Both of those things increase the chance of blood clots and strokes. And another thing you may not realize is birth control for women, birth control pills, will greatly increase your chance of a stroke. So one thing you should never do is smoke while you're taking birth control pills. So then you're really are asking for problems with that one. This last section, I'm going to bounce around just a little bit. I'm going to just mention the hepatic portal system. A portal system, by definition, is when you have a vein that is connecting two capillary beds. Ordinarily, what you would have would be a capillary bed going to a vein that would go to the heart. But here, what we have, anytime you have a portal system, there's really only two examples in the body. But you have a portal system, the capillaries go to a vein, then it goes to another system of capillaries, it goes back to another vein, and then it goes to the heart. So here's your portal system right here. So what this is representing for the hepatic portal system, these capillaries are picking up all the blood flow from the absorptive areas of the intestinal system. So basically the small intestine. This capillary system is spreading out through the liver. So we have the portal vein and we have the hepatic vein. The reason your body does this is that way it can take all the blood from your small intestine absorptive surfaces and examine it really, really closely in the liver. It can try to remove any pathology, any invaders, any bacteria that might have hitched a ride. It can take out all the nutrients that it wants. It can try to detoxify the blood's coming through there. Then when the body is satisfied, when the liver is satisfied that the blood is good to go and it's extracted what it wants to, then it's going to go ahead and put the blood back out into the venous circulation. We're going to be talking about portal circulation again when we talk about the digestive tract. What you need to know at this point is simply what a portal system is. It's capillaries to vein to capillaries to vein. And I want you to know that it goes from the small intestine to the liver. When we're talking about circulatory differences and exceptions in circulation, let's talk a little bit about fetal and maternal circulation. The umbilical cord contains two umbilical arteries and a single umbilical vein. And it's through these vessels that the baby is getting all its nutrition and getting rid of all this waste. So remember, we've already talked about in chapter 20 that before birth your lungs are collapsed. So your heart does not see any big need to send the blood through the lungs. So it's going to bypass the lungs for the most part by two structures. One's called the foramen ovale between the two atria, and the ductus arteriosus between the pulmonary trunk and the aorta. The baby's blood does not flow directly into mom's blood. It has a unique structure in the placenta where it comes very close. It's just separated by a couple of membranes, but it's not supposed to mix and mingle. Now, in real life, obviously it does during birth, during childbirth. When you're pregnant, things are stretching, things are expanding. You're going to have some leakages. That's why we talked about in chapter 19 the RH factor. But the system is designed so that the mom's blood and the baby's blood don't actually mingle. So we'll mention this again when we start talking about this in chapter 28, but you'll see from this diagram here that you've got mom's blood here, what they refer to as a sinusoid, and then coming from the umbilical side, you've got the baby's vessels here. And so across these membranes, you'll have transfer of oxygen and nutrition and waste and carbon dioxide. Then at birth, the umbilical cord is going to be clamped, usually by passing through the birth canal, or simply if it's a C-section by the doctor tying it off. The blood oxygen level is going to decrease. That's going to stimulate the respiratory center in the brain to cause inspiration into the lungs. You've seen the movies where they used to swat babies on the butt. They really don't do that anymore, but what they're trying to do is make that baby take a deep gasp in, and that's going to inflate the lungs. That's going to cause blood now to increase into the pulmonary circulation, which is going to drop systemic blood pressure. And then if all is going perfectly well, then the foramen ovale and the ductus arteriosus will close. These last few slides, and I've worked hard trying to find something that really tells everything I want to show you on here. You'll actually find my most updated versions under course documents. But things you need to pay attention for, if you look at these blood vessels, a lot of times you'll actually see the blood vessel. It's the same vessel, it just has a different name depending on where it's reaching in the body. For example, the subclavian artery is going to be stretching into the axillary artery, which is going to be branching out into brachial arteries, and just keep on going. So you need to make sure you can identify on a diagram the carotid arteries, the vertebral artery. Make sure, of course, things like the abdominal aorta. Let's see here. I've got some slides posted under course documents showing you some better pictures of all the aortal vessels here. Recognize things like the iliac, and that includes common, external, and internal. It starts out common, then it branches out. You've got a more superficial external branch, and then you've got the deeper internal branch. You've got the femoral artery behind the knee. It is referred to as popliteal, coming down to anterior and posterior tibial, and then you've got the perineal artery. Over on this side, you'll see things like the radial and ulnar arteries. Those are pretty easy. Remember your location of your radius under your thumb and your ulna under your pinky. This slide actually includes a lot of the veins. You'll find, for the most part, your arteries and veins are going to be called something pretty similar to each other. So pick up on terms like cephalic. You remember cephalic means toward the head. So I want you to make sure you pick up on the fact that it's a median cubital vein. And I've got that on the next slide showing you where blood is taken from for the most part. Anytime you see mesenteric, you should think intestinal tract. I was looking on here, seeing if is there any other thing that I need to really point out. But so again, know things like the subclavians, both arteries and veins. You can refer to your list that you're passed out in lab. And I put this slide in here again pointing out the median cubital. So if you end up doing any venipuncture, but let's say you're going to be a phlebotomist, that's going to be your target. Be nice to them. Okay, that concludes chapter 21. I realized we kind of bounced around. I was trying to follow the format of the book, and it ended up causing me to go back and forth more than what I normally like to do. But I really tried to point out the most important things, get you to understand the concept of vasomotion, know the big differences between arteries and capillaries and veins, and know the different terms for them. Make sure you understand a general, we're not really getting into chronology yet, but understand the sodium savers and sodium losers. So I will see you in class.